All right, chapter 34 discusses multi-system trauma. So patients that have numerous injuries and how to manage that. So if you hear the term multiple trauma patient, it means there's more than one serious injury. Multi-system trauma, one or more injuries are affecting more than one body system itself. So using teamwork, resource management, how much help do you need? That's the main reason why calling for additional help is in the primary. And then whether, making your transport decision. So the biggest critical decisions we need to do on these multi-systems. Patient priorities. Are we going to stay on scene? Do we need to just stabilize and get going? Remember, the best care these patients are, the most definitive care is at the hospital. Which hospital can we go to? Right? Do we need to go to a level 1 trauma center? Do we need to go to, can we go to the closest hospital to stabilize and call a helicopter? These are all going to be things you'll need to think about when you're on scene with these serious accidents. Determining severity of the patient, just some guidelines. Altered mental status, okay, head injury, low blood pressure, which signifies your patient's in late stages of shock, internal bleeding possibly. Abnormal respiratory rates, way too high, way too low. Pelvic fractures. Remember, the pelvis holds an immense amount of blood. So having that unstable is going to be a life threat to your patient. Skull fractures, depressed fractures, so the brain is impacted. Any paralysis, they can't feel you touching them. They can't follow commands to wiggle their feet or their hands, their fingers. Amputations. Penetrating injuries, so knives, impalements, head, neck, torso. Chest wall instability, so that paradoxical motion you're seeing, chest deformity, flailed chest. These are all severe patients. 2 or more proximal, meaning next to each other, long bone fractures, crushings, deglovings, manglings, pulseless extremities, indicating that late sign or that shock is body starting to shunt blood. In absence of any anatomical or physiologic signs, look at your mechanism of injury. So I'm going to show you hours here for Mayo Clinic in just a second. I have a card that's triage criteria card, and I will share that with you. I'll copy it so you guys have this. So falls, depending on how high the falls are. High risk crashes, so any intrusions more or greater than a foot. So somebody smacks an electric pole and the impact is more than 2 feet. Just think what that's doing to the human body. Ejections, no seatbelts from the automobile. Any fatalities in the same compartment, those patients are severe until ruled out. Remember, older adults do not efficiently compensate for shock, neither do your peds patients, right? So patients that are taking anticoagulants, we've talked about this before. So Coumadin, warfarin, Plavix, any blood thinners on board, any trauma patient you have, you should be trying to find out this information. Look for bracelets if they're unresponsive. Pregnancy, where we've got another human being on board, is determined critical. So I'm going to stop sharing and I'm going to show you guys this thing here. So Mayo has this little triage criteria sheet that we have in our pocket, and it kind of has a flow chart. Altered level of consciousness is first, and then it says yes or no, and then you follow down. Do we have respiratory distress on board? Is there shock? And then they kind of give you is the blood pressure look like, is it less than this systolic, depending on your age of the patient? Is the heart rate within these guidelines? So it's kind of a nice guideline as to what to do with certain or multi-system trauma patients. And then on the back of this, it kind of tells you how they would be considered at the ED. Okay, so is it a level 1, the most severe? Okay, the most serious patient. Is your patient falling, in these guidelines? Are you seeing these pressures? Are you seeing these respiratory rates? Or is it a level 2? And it also gives you, if you notice, the mechanism of injury. Okay, that's going to be considered a severe or critical level 1, or is it going to be a level 2? So I will copy this. I think it's a useful piece of information to have. You might get one from your services, but just kind of give you an idea of guidelines that we follow on these multi-system trauma patients. So as far as care goes, no matter what, how severe, what degloving, angulated, what kind of whatever you see, do not get tunnel vision. You need to recognize how severe is that patient. Do you need additional help? Do you need helicopter? You are always and forever going to stick to your ABCs. If anything else, stick to those ABCs, because without that, you're not going to have a viable patient. Okay. What should be managed first? That's why we have the order of assessment. This is the key time when you're going to use that order of assessment. What's the scene look like? How many patients do we have? Do we need additional help? Do we need to take C-spine first? How's our mental status? What's our patient look like? ABCs. Who's going to, what's our transport time? Where do we need to go? Who will accept this patient? So the previous scenario shows an example of a patient has critical injuries. Yeah, and so we've been doing these, guys. We've been doing these in class, so we really don't need to go over that. So we're going to kind of skip that. So determining the roles, all right. Following priorities, your primary all the time, like I just said. Need for critical trauma patients to get to surgery within an hour. So we like that golden hour, okay, from the onset of the injury to the surgery room, okay, 1 hour. Now that's going to be really tight, right? Especially if it takes you 20 minutes to get somewhere. But I think the point is time is of essence, okay? Time is very important. So just making sure that you are rapidly transporting at the same time, making sure that you've got, airway breathing and circulatory stabilized so you can do that. So like they said, and like I just went over, another one, control your bleeds, right? You've got a volatile bleed, you got to take care of that. You've got to restrict spinal motion before we go in motion. We want to limit further injury to your patients. Performing urgent or emergency moves. My goodness, that was week 1. How many years ago, right? At least it feels like it. How to get people out of cars faster. Can we take our time? Do we need to emergently move them out? You're going to have to adapt to every situation because every trauma is going to be different. Of course, pediatric younger patients aren't going to understand what's happening to them, what's going on around them. So make sure you take the time to connect with these pediatric patients, explain to them what's going on, just like you would with your adults. There is a trauma scoring sheet. I haven't seen it in practice very often, but it's just another tool to help you determine, do we have to go to level 1, 2, 3? And so when we're talking about levels of trauma centers, all that means is they have the capability and the staff to do more or less invasive or less options. So it's based on their volume as well. So like your Gunderson is a level 2 trauma center, very capable, can handle serious injury patients. Mayo or St. Mary's in Rochester is a level 1. Once again, same caliber, probably just more patient coming through the door, more patients coming through the door. Your level 3, 4, and 5 hospitals are probably not going to have the capability to handle real serious patients. They can help stabilize, but they're going to, and eventually either helicopter them out or take them to a level 1 trauma patient, depending on the severity and seriousness of your patient. So they may not have an orthopedic surgeon that's just there. They might have to page one in. So make sure that you're aware of what hospitals you have around you and their capabilities. Okay, so it's all about time. It's all about preserving time, getting the patient to definitive care as soon as we can. So the Glasgow Coma Scale, this RTS, or the Revised Trauma Score. So what it looks like is the Glasgow Coma Scale. It's going to look at your systolic or your top blood pressure number and your respiratory rate. Okay, so as you can see, if the Glasgow Coma Scale number is X, they get this many points. If their top number is greater than 89, 75 to 89, they get, X points. And then what's their respiratory rate? Are they up there? Is it 10, is it greater than 29? Is it low? And then they kind of give you a trauma score. So like I said, I haven't seen this in practice very much, but it is there. So based on what you know, based on what you have in the book and the exercises you've done, you have a patient involved in a car crash. Significant intrusion to the area where the patient was sitting. The patient's alert. He complains of pain in his ribs. Pulse 96, regular, respirations 30, adequate, blood pressure 100/62. Pupils are equal and reactive, skin is cool and dry. So you have a lot of information. Write that information down and take a broad look at it. Take a broad look at it, where your patient's injuries are. You have a car that's had significant intrusion into the area where that patient was sitting. So whatever force caused that intrusion, think about that. Think about its impact on the human body. So your partner says, this patient's good enough. We can go to the local community hospital. You say, no, he needs to go to the trauma center due to what I see. So how would you justify your decision to your partner? So I want you to think about this. I want you to look at the information you were given, and you have some pretty good clues in there as to why this person needs to go to a higher level trauma center. Okay, so put that together and we will discuss it when time permits.